Good day, and welcome to the first of two webinars on optimizing infusion therapy outcomes through pharmacy nursing collaboration. My name is Jackie Cole, and I'm a medical science liaison for infusion therapies and technologies with Baxter Healthcare. I'd like to begin by briefly sharing with you why we're hosting a webinar on this topic. Our MSL team is composed of pharmacists and nurses, and my nurse teammates frequently reference the Infusion Nurses Society, or INS, Infusion Therapy Standards of Practice. This was not a reference that I was familiar with as a pharmacist, and when questioning other pharmacists, I learned that they were also not familiar with it. I had an opportunity to serve as a practice reviewer for the most recent standards and realized the value and applicability of the standards to both nurses and pharmacists. So as a result, my teammates and I discussed with today's presenter, Barb Nickel, the opportunity to share some key practice recommendations from the standards in a webinar that would highlight how the standards promote collaboration between pharmacists and nurses. In further discussion and planning, it was evident that it would likely take more than one webinar to adequately cover the content. So that is how we arrived today, with two webinars being planned. Barb, if you'd like to advance to the next slide. Before we get started, I'd like to go over a few items so that you know how you can participate in today's event. You see here a screenshot of the attendee interface. You should see something that looks like this on your computer. You will have the opportunity to enter typed questions into the Q&A window. To activate the Q&A window, click on the Q&A icon at the top of the webinar window. The Q&A window will open on the right side of your screen, and you may type your question in the field labeled Ask Your Question here. You can enter your question at any time, and we'll address all of the questions at the end of the presentation today. Next slide. At the conclusion of the webinar, you will see a QR code for a brief survey. Please take a few minutes to complete the survey, as this will inform us on topics for future webinars. Next slide. Now I'd like to introduce our speakers. Barb Nickel is a clinical nurse specialist at a large healthcare system in the U.S., responsible for staff development and process improvement to optimize outcomes in multiple areas of clinical practice, including critical care, infusion therapy, sepsis, and new graduate transition to practice. Ms. Nickel has presented nationally and published in several peer-reviewed journals on infusion-related topics, was the chair of the 2024 Standards of Practice Committee, and is now chair of the 2027 INS Standards of Practice Committee. She also serves as adjunct research fellow for Griffith University, Queensland, Australia. Scott Murray is a seasoned pharmacist with 30 years of experience, over 20 of which have been dedicated to hospital pharmacy. Currently, he serves as a senior pharmacist and medication safety coordinator at a leading academic medical center in central New York. He is a member of the Pharmacy and Therapeutics Committee, Quality Patient and Safety, Accreditation Readiness, ISMP Medication Safety Officer Society, and the American Society of Health System Pharmacists. He has worked as a satellite pharmacist in several areas, including the emergency department, ICU, neurology, and orthopedics departments. For the past 18 years, he has chaired the Medication Safety Committee, leading initiatives to improve patient outcomes and streamline processes. He is also trained in Lean Six methodologies, holding a yellow belt and working toward a green belt, and ISMP safety certification expected in December of 2024. Through Scott's role in the Medication Safety Committee, he has worked collaboratively on many vascular access-related improvements with nursing and helped to implement a saline-only flush policy, comprehensive infiltration and extravasation policy with the medication treatment chart, IV push policy, USP 797 and 800, ISMP targeted medication safety practices, and ISMP self-assessments. I'd like to welcome our speakers, and at this time, I'll turn the presentation over to Barb and Scott.
Thank you so much, Jackie. We really are delighted to be able to bring this webinar to you. Both Scott and I have a great passion for delivering quality and safe medication administration, and this is really in the infusion therapy space. And so we'll share with you a little more about what the INS standards are and why then this webinar came about. to add to Jackie's excellent introduction. So our objectives for today, to describe the impact of effective interdisciplinary collaboration between pharmacy and nursing on patient outcomes, giving several examples throughout the extensive careers that both Scott and I have had. Identify barriers. When do we not communicate well, and what can we do to mitigate those issues? And then really talk throughout about best practices, including some case studies at the end, and really representation of some very good resources at the end as well, with time then for questions and answers. So again, we'll talk about these things. We're going to lay a foundation today about that collaboration. And as Jackie mentioned, we have a part 2, because one of the areas of collaboration that both Scott and I have worked extensively in, and we knew that we would not be able to give it justice in this webinar, was extravasation, prevention and management. And so the webinar on December 18th will really build on this foundation and then go much deeper into the area of extravasation. So we'll touch on it very briefly today, and hopefully you can join us on the 18th of December for that particular webinar. So a little bit about the, the infusion therapy standards of practice. Jackie already did a great introduction to it. And yes, I don't believe that it's well known outside of or in the pharmacy realm. The parent organization is Infusion Nurses Society, INS, and that's what I'll call them from here on out. So it is a parent nursing organization. But this document, although it started very much as a home care nursing document, it has become so much more over the years. The picture that you see on the slide is the 9th edition that just came out in January of 2024. And it really represents now, it has grown so significantly over the years. And it's been, I believe, the 9th edition, I believe it's been around for at least 30 years. Again, every edition we make more applicable to a broader range. And so it is now really a global standard for infusion therapy. It is used worldwide. It's translated to multiple languages. It is multidisciplinary. We pull from references from radiology, from respiratory therapy, from pharmacy, to make sure that we really are in lockstep with those particular standards as well. So it really can represent a common language for nursing and pharmacy to interchange when we do process improvement and deliver care. We also had a pharmacist on the 9th edition committee, and Scott actually is joining the 10th edition committee that we're just now standing up as our pharmacy representative. We've added a provider as well to the 10th edition. We have representation of 4 different countries on the current 10th edition. And we had similar on the 9th edition. So again, it's global in perspective. It's also global in application. So we really try to address all clinical settings, not just in the US, but even in low resource areas such as South Africa, South America. And so we're really trying to create a resource to help guide infusion therapy across the world. It does apply to all age ranges. It is a 3-year review cycle. So again, published in January of 2024, and we just started work for publication of the 10th edition early in 2027. This current edition that you see has over 2,000 references that are housed within 66 different documents within this particular edition. And we'll have a look at what some of those are that really have a great deal to do with both pharmacy and nursing. So within the document, I've given you a good look at just probably about a third of the content. And on the left, you see the sections. We have 9 sections that represent broad buckets within infusion therapy. And then within those sections are housed the standards themselves. And so if you look at the top, section 2 is patient clinician safety. And so some of the standards that really apply both to pharmacy and nursing: serious adverse events, product management, drug diversion, which was a new standard in this edition, hazardous meds, medical waste, infusion equipment, meaning flow control devices, and not just the dose error reduction smart pumps, but really how do they deliver safe care even when they don't have the access to pumps. Blood and fluid warming, vascular access devices selection. We'll talk about that some in this webinar, but more significantly in the following one in December. But looking at the different access devices that we have: ports, interosseous, umbilical catheters, VAD management, A couple of them within that section: filtration, very important for both of us; flushing and locking, as Scott alluded to, a saline only process that really includes both nursing and pharmacy. Bad complications, again, how do we mitigate those? And again, we'll talk about extravasation in more depth in December. Other infusion devices that might deliver infusion therapy, and you can see that they're listed, and then specific infusion therapies, compounding, preparation, medication administration, how to do that safely, and then really get into very specifics: antineoplastics, biologics, vasopressors, etc. So again, there is so much depth in what we cover, and that applies to both nursing and pharmacy, and building this kind of collaboration and using this document as a shared body of knowledge is very, very helpful. So I'll turn it over to Scott.
Okay, thank you, Barb. And I'd like to take the opportunity to thank Baxter and Barb for this opportunity to speak. So as Barb alluded to in the INS standards, the things we're going to talk about in these opportunities for collaborations are going to be really in these areas. Product issues, you want to think of IV products that, infusion products that nurses use daily. Could be those vialomates, those chambered bags that have the diluent and the active, and maybe they don't get popped and can get infused. USP 797 is a big one. 11/1/2023, the guidelines were updated and they're enforceable now. And you want to think of those topics like BUD, beyond use dating, IV push requirements, and compounding. Dose accuracy, how are we ensuring dose accuracy in collaboration with nursing and pharmacy to help that with, say, in order sets and delivery. Innovation. In this area, you got, again, order sets, smart pumps, guardrails. There's all these opportunities we're going to get into. Next slide, please. So getting right into it, one of these opportunities, product shortage, product issues and shortages. Long-term or prospective, with certainly consistent communication between pharmacy and nursing and participation in P&T. This helps mitigate this on a long-term and prospective basis, but that nursing and pharmacy collaboration can also be on the reactionary or right at that time when we start getting the heads up that we're going to get shortages on meds. Where can we conserve it? Do we have a good enough stock? And then as we're doing that, we develop with P&T, we can do alternatives. We can ensure that there's other products that we can get in, dosing, equipotent dosing charts. And these collaborations are integral for this. And where we really see this is, and we'll get into later, when you have ER pharmacists or in code participation, that a lot of the Bristol-Jets that we're talking about, D50, epinephrine, and so on, that go on back order, and pharmacies may necessarily have to kit those. And that collaboration with nursing and pharmacy, and realizing that, you know, if there's 6 sodium bicarbs or D50 in a code cart, that we're going to have 3 Bristol-Jets in the cart, but then 3 kits made so that a nurse can get going with the provider and get that patient taken care of. And then another nurse or another person, maybe even your ER pharmacist, can start drawing up with the vial and a syringe in a kit.
And building on the life support medications, pediatric applications. So many times you're not giving D50, you're giving D25 or even D10 into a neonate. And how do we deliver that so that our nurse isn't trying to dilute a drug right at the bedside of a coding 6-month-old? Or bicarb, instead of 8.4%, 4.2%. And how do we get rid of that dilution? Can we deliver those drugs right at their fingertips so that they're giving an accurate dose? Another example is ketamine during COVID. I'm from a relatively small community hospital. We were slammed with COVID because we have a large Hispanic population, and there was a large quinceanera in our neighborhood as the COVID broke out. And so we were just really, we had a large surge. And what we found was that in these patients, especially ones that were paralyzed, that their blood pressures were very low and they could not tolerate propofol. And so we actually, on the fly with pharmacy in a really a 24-hour period, developed a ketamine sedation protocol that incorporated vent synchrony, because many of these patients, train of 4 didn't work. They were edematous. And so we weren't able to use that to titrate their neuromuscular blocker. And so it was a complex protocol, but it was really developed on the fly, very effective. We watched it very carefully to make sure that it was correctly used and really did create good outcomes. And another one, a more current one, is the Ativan shortage. In my large system, we created a new alcohol withdrawal protocol that allowed us to reduce the usage of Ativan for that particular population. It has a provider order that has a low dose option if the provider estimates that it will be a less severe withdrawal, and it has lower doses of Ativan, POIV, even Neurontin in that particular one, and obviously Librium. And then if the provider anticipates a longer, more severe withdrawal, the orders are potentially higher doses of Ativan, but they can use phenobarb instead. And it really has created some good outcomes in these patients. It has a longer half-life. It actually has it actually has been very efficacious for some patients. And so again, a longer term type of a protocol, but very, very effective communication.
Yeah, and another opportunity for this kind of collaboration, as we all have seen with the IV fluid shortage, if the gut works, use it. This has been an opportunity with nursing and pharmacy. One of the things, actually, even just prior to the fluid shortage that paid off some dividends is we had a nurse-led quality improvement thinking about potassium, that, you know, why are we doing IV potassium? And potassium, if the gut's working, is well absorbed. And that wound up paying off dividends in the fluid shortage to utilize the gut more and reduce that amount of time that we need to use those IV fluid shortages. IV push policy, that actually can help with the fluid shortage as well. With this can also can be time saving, can be resource saving from nursing and tubing and what have you. And this is something that actually can also, with that collaboration, be built into a policy, and institution can decide for certain patient populations that maybe push is better. Pumps have safety with the guardrails, but IV push also, in my collaboration with INS and with our nursing here, that IV push can be a little easier on the lines. The collaboration has helped with that larger fluid, getting that large volume fluid, getting that time frame down to 24 or 48 hours, like an automatic stop date. And that way these orders don't go unchecked. And if the patient needs it, these orders can always be renewed. But really working with nursing to identify that patient population and streamline utilization of the large volume fluid. And one of the things we've all seen that's popped up on some of the sites and in the literature is, you know, albumin for severe fluid repletion or shift. If instead of using multiple liters of fluid for volume, you can command that oncotic pressure with albumin and identify those patients that it's acceptable for. Next slide.
Yes. From an INS perspective, the fluid shortage has been something that INS has been very integral in. They have met with multiple entities on it, on how can we apply best practice, safe practices, so that we're delivering correct care. We are conserving fluids and yet still maintaining quality of care. And that's, I think, very, very important. I think, as Scott alluded to already, that this really has been an opportunity to give us thoughts about how can we do this on an ongoing basis. So yes, we're doing some things because of a catastrophic event, but some of these practices, I believe we need to look at and really probably carry forward and say, we need to continue to do this because it really is delivering good care. We need to ensure dose accuracy, though. I heard of a system that really was in a shortage of fluids, and they had asked their nurse, this is anecdotal, but asked their nurses to deliver antibiotics, even vancomycin, on gravity tubing and drain the tubing to make sure the entire dose went in. That puts a great burden on the nurse to be able to say, did the vancomycin go in the right time frame? and then make sure that we aren't losing the line at the end. It is still much better to use a carrier on those, and I'll talk about that here shortly. We need to validate incompatibilities. Again, as we shift practice rapidly, and such as we did in COVID and maybe in a fluid shortage, we need to make sure that we are doing the right things. If I'm giving an IV push drug that I haven't given before, is it compatible with the carrier fluid? Do I need to flush first and after? And if pharmacy can give me those administration instructions, that would be very, very helpful. A correct use of the pre-filled saline syringe. We have the ISMP safe practice guidelines on the side. Very important that nurses know this document, but I think many of them do not. And I've asked, do you know what ISMP stands for? Many of them do not, and I think they need to understand it better. A pre-filled saline syringe is a flush, and is a flush and is a flush. It is not a diluent, but unfortunately, sometimes workarounds can happen, and we need to help them to understand why, that it is a flush, and that's really its only purpose. Again, administration for IV push medications. And then one of the requests, the INS standards would say 24 hours of hang time for any non-additive IV solution. However, there's really not a great deal of science there. There's one recent study that looked at CLABSI rates, but CLABSI is really a surveillance definition that doesn't really give you a causality. And so we need to study that further to say, what is the hang time? Often this is really just the carrier fluid that we might be using to deliver secondary meds. And as availability, if we can use a 250 ml bag on that, then hang time really isn't an issue because it's not going to get to a 96 hour. If we have to transition to using a liter bag for that carrier fluid, then we need to consider what are all the ramifications there. So again, we need to have conversations to understand both sides of the fence and how does this really impact practice.
Okay, so this next section, I apologize for the content here, but it's important for a couple reasons. This is the updated USP 797 and the section on immediate use. And these are the 7 requirements that are there now when preparations are made at bedside. But it's really the highlights of this that are what we're going to concentrate on, that in your policy and procedure, and think about the collaboration with pharmacy to help develop this, that we need to be using aseptic technique and that they're followed, and that the personnel that are doing this are trained, and the big thing, demonstrate competency in the aseptic technique, and that practice is performed and, of course, has evidence-based behind it. And one of the big things to concentrate on is that it's not more than 3 products, and that includes the diluent. And you do even want to think about those areas, say the OR. Sometimes the OR, from what I understand, and you could possibly hear, is that there are 4 or 5 and maybe even up to 6 products going there, including the diluent. So if that's the case, then by definition, that actually has to be compounded in pharmacy. And how does that impact that institution? If that's the case, we've got to think about lead time. And that if the first person, that it's not for more than 1 patient, and these are single-use vials, and that we're going to get rid of that after we use it, even though it can seem to be wasteful on the vial. And that the administration is started within 4 hours. And one of the lot of questions that we'll get is, it's not finished in those 4 hours. It's just that it started within those 4 hours from the preparation, preparation time, excuse me. And that, hey, if you're not that person that made it, then the person that, if you're not the person that made it and you're administering it, that the person that made it, that there's labeling on there that includes the drug and when it was made and what volume it's in and so on. So the labeling on there. Next slide, please.
So just to show that this content really is reflected within the standards, we have this standard 56, compounding and preparation, and our pharmacist on the 9th edition was integral in this standard. So again, it's not a repeat of the 797 USP, because that would be exhaustive, but it's really looking at that from a nursing and an infusion lens. And so again, we repeat this information. knowing that there are people that read our standards that really don't have the same resources that we have in the United States, nor the same guidelines. So it's really reflecting what is best practice, what do we need to work toward. And I've talked to people from many other countries that use the standards, and it's like, we can't do this, but we know where we need to get to. And so again, that's an important piece to the standards, really showing where should the bar be set, where do we need to work toward, even when their resources don't allow it. So it also applies to areas that have maybe an absence of 24/7 pharmacy, where nursing may need to step into this space. And how do they do that? And making sure that there is good communication and that they're doing that effectively. So competency in that area. I recently did a competency with my staff on simple reconstitution of Rocephin, which is not compounding, but it was amazing to see how many different ways that nurses did even that simple task. One important fact, how many nurses thought that when they popped the top off of that vial, that the rubber stopper underneath was sterile? It obviously isn't, but that has been a thought that we were able to dispel. And just the amount of splash that happens because they're not managing volumes. Again, making sure dose accuracy when they pull this up is very important. So even a fundamental task like that, there was significant variability, which makes you wonder what happens when it's a little more complex. I'll hand it back over to Scott.
So on the reconstitution side, there's a couple things to consider. One, now there's a statement out there that we shouldn't be using pre-mixed commercially available, pre-filled commercially available normal saline flushes. And you're going to remember this came in place at a time where flush bags were out there. And then that was officially recognized as not acceptable. It was either flush bag, and that was drawn in to reconstitute things. And in a vacuum, with nothing officially out there of how we're going to do it, practices like this are going to come into place. And it's put out there that to not use these by the FDA, because these are devices, they're not intended to reconstitute and or be the vehicle to administer medications. Do not over dilute. That's out there with ISMP, as I again have learned more and more working with our own nursing here and with INS, that this can cause complications in the lines. So if the manufacturer, common one like morphine, if it can be mixed in normal saline, 5 mLs are given directly, then you go ahead and give it directly, safety for the patient, and certainly with IV push guidelines, but do not over dilute. And IV push versus infusion, this is an opportunity for, again, going back to the fluid restriction, thinking of the ISMP guidelines for IV push. We can conserve resources, either nursing time and or tubing, pumps, what have you. Next slide, please. So this was an opportunity for collaboration with pharmacy and nursing, and in this case, medication safety, that when we were talking about, and as Barb had mentioned with ISMP, we actually at the institution did the ISMP IV push gap analysis to see how our practice measured up and looking for those quality improvement areas. And we were doing this in anticipation of the 2023 USP guideline update. And in this case, the IV lab director took the opportunity to make 3 short videos of common preparation with making a product at bedside, looking in anticipation for the IV push practice with nursing. And we had 3 options here. And essentially with this, there's one option with 1 syringe and a couple options with 2 syringes and or 2 needles. And this was an opportunity to show that 1 syringe and 1 needle may be fast and the least amount of equipment, but can lead to a little bit of inaccuracy, because if you're drawing up the active ingredient and then draw up the diluent, the syringe plunger can go back and you can get product back into the vial, whereas 2 syringes and 2 needles can be the most accurate, because you would draw out of the vial the active ingredient, with one syringe, and then you would draw up the volume of the diluent in another syringe, and you use a connector, and you're going to have the most accuracy and no chance for either product, diluent or active drug, to go back into the vial. So this was an opportunity to put this out here for nursing, and the nursing can apply whichever one's accurate and most appropriate for their patient at that time. Next slide, please.
And these are issues that especially new grad nurses aren't necessarily even aware of. They aren't getting this kind of detail in their basic training.
So then USP 797, along with that, of course, is USP 800. And this was an opportunity to collaborate. So USP says that you're going to do a look at all your current products on there, and we're going to classify them. Remember, there was a table 1, 2, and 3, and it's now reduced to just table 1 and 2. And this was an opportunity for the hospital to do that, look back at their inventory, classify them in these areas. And essentially your table 1 is that it's been demonstrated to show that it's a potentially a carcinogen, and that there's or cytotoxic effect to the tissue. Whereas table 2 is that this is more reproductive, potentially a reproductive effect in those folks that are exposed to this in reproductive years. Next slide. And then there's category A and B. And of course, category A is the fact that you have your table 1 drugs, and if the if a nurse has the giving something that is not in a full final dosage form, that they would not be able to manipulate that or compound that. And you want to think of anything that's an injection or liquid, or even think of something that like a drug tablet that's a hazardous drug and it needs to be crushed. These are things that cannot be done by a nurse, must be completed by pharmacy and sent to them in that form. So like if we would we'd crush a tablet that's hazardous, and then we would put that in a safety bag and for the nurse to administer. Next slide. Whereas the category B is something that's full intact, and you want to think that these are tablets that are hazardous, but if you're giving the full tablet, a nurse does not need to be in full PPE. The nurse can give the tablet simply with gloves. If this is an injectable, this is an infusion, but it's primed with the chemo, and we're simply connecting this to the patient, then the proper PPE can be utilized. Next slide.
So building on that, again, we just did a competency and really having our nurses look at the table of hazardous drugs. And yes, the automated dispensing cabinet tells them, is it a tier 1, a tier 2, a tier 3? The medication administration record, the MAR, says that. But are they using that as actionable information? Are they looking at the grid to say, how do I need to protect myself? And so we reminded them and found that, yes, some of them knew that that's what it meant, but they weren't looking at the tool that pharmacy had created to help them to stay safe when they're preparing a hazardous drug. So again, those need to be reminded and reinforced. So the guide that we have on the side is from ISMP, and it's a great collection of what do we need to do when we're thinking about process improvement. And you can see the human reliability at the bottom, the low leverage things. And I love it when people say, well, let's just educate on this. And that's really what it is just education. It's a very low level intervention. It is important. It's a foundation. They have to hear the why, but then we have to reinforce. We have to cover it from different angles. We have to then do more high leverage, especially on higher risk issues, so that we automate it, so that we create fail safes, things like barcode medication administration, smart pump guardrails. Why is there a hard stop on this drug at this level? Making sure that we're not making those decimal point errors. So again, those guidelines are very, very important. And then not allowing folks to bypass them, really setting up accountability. between pharmacy and nursing leaders to say, you know, here's what our goal is for pump library use, and here's why. Here's some of the errors. That's what we did in our last competency, is showed them what are some of the errors that were avoided by the drug the guardrails in the pumps. But looking at granularity, I know a facility that had a significant downturn in their barcode administration record or scanning rates, and they looked into it and got down to the individual user and found actually that a traveler was a significant number of the failures to scan. She didn't realize she had to scan both the med and the patient. Apparently that was missed in her onboarding. And so again, looking at those things, because again, there was probably errors that occurred that maybe were missed. So monitoring compliance and truly making sure that the actions that we're doing and working together on are sufficient based on the risk. So again, INS standards for safe medication delivery, we address it on the smart pumps, as we've talked about, the guardrails, making sure that facilities, if they have this capability and run these reports, that they maintain a threshold of 95% or greater, and that they work toward that. And again, that's work between nursing and pharmacy. So very, very important to do that. Another tool that we have in the standards, are the 5 rights enough? Actually, what the research is saying is that no. If you ask any nurse, they could in even half asleep tell you what the 5 rights are: the right patient, the right route, the right dose, the right med, the right time. But does that really keep their patients safe? No. And that's really what the research is showing, that there is so much more nuance around medication safety. Is it the right time to be giving low pressure to this patient? Well, no, his systolic pressure is 90. Or am I treating a high heart rate with low pressure for the right reason? Yes, maybe, but if they're severely septic and the tachycardic is compensatory, then no, that's the wrong thing to do at that time. And nurses need to have the critical thinking ability to apply, is it the right time, or is it the right implication, the right labs, the right vitals? Am I the only nurse giving this medication? I just got them from the ED. What did they give and when? When do I need to return? How do I need to monitor? What kind of safety? Nursing schools are actually teaching 10 to 12, even up to 18 rights now, which is a little bit crazy in the complexity range. But again, the 5 rights is not enough. This is actually what's called the Warriors tool. Our pharmacy works with nursing in our system to put out safety alerts to say, here's how, you know, this was a near miss, and here's how the nurse used this tool to provide safe patient care. So a little bit about this table. I'm going to go quickly just for time's sake, but we actually saw some overlap between 2 standards, and we felt that this table of delivery could be very helpful. And so we distilled the new research in medication administration and in how we use administration sets, filters, and tubings to deliver dose accuracy. So very quickly, again, intermittent secondary medications, very important, small volume, 50 to 100 mLs. If that's an electrolyte or a antibiotic, there has to be a carrier with it. Fluid shortage or not, that's really a non-negotiable, so that we deliver the full dose and do it accurately. Most tubing has a priming volume of maybe 25 cc's in that range. So quite a bit of dose can be lost if we don't do it consistently from nurse to nurse. And it really needs to be considered for any secondary medication. My system looked at it. I created an algorithm for our national pharmacy to say we have to use a carrier for a small volume. If we didn't for these large volume, like a 250 vancomycin, we are changing workflow for our nurses, and we are likely going to have quite a few med errors. And when they looked at my algorithm and what that really meant, our system decided, no, we're not going to go that route unless the fluid shortage gets worse, and then we'll consider changing workflows. So a quick safety story: crashing patient comes into the ED, low blood pressures, the doc orders 30 mLs per kilo of fluid, and pressures are still kind of low, and so he orders a norepinephrine drip. Comes up in a 250 bag, the nurse primes it, scans it onto the MAR, also orders vancomycin. A 250 bag comes up, the nurse puts it on primary tubing, scans it into the MAR, gets distracted. It goes then later, the blood pressures are better, the norepinephrine is not needed, but it's on standby. Goes to hang the vancomycin, grabs a 250 bag, hangs it on the pump, runs it at a vanco rate. Which one did she pick? They looked identical. In this safety story, she picked the norepinephrine and ran it at a Vanco rate because the workflow for secondary meds needs to be the same. The workflow for high risk medications like pressors needs to be the same. Again, that's something you need to look at in your system. We've already talked about IV push medications and how important it is that nursing has the ready information. How do I do this safely? What's compatible? How fast do I need to deliver it? Especially if I don't have a syringe pump to do so. More than one medication delivered to a patient, making sure that I have a consistent process to map those tubings so that I know exactly what's going in which line. Patient movement, making sure that there's no entanglement. High risk medications always on an individual primary line. If I have to change concentration from a single to a quad strength, changing the tubing and then having that bag ready for when I reprogram the pump so that I'm delivering the exact dose immediately and there's no change in volume within the tubing. And then multiple infusions, if I'm daisy chaining several into a single lumen because I have limited vascular access space, and I have something going at 4 cc's and at 20 cc's and at 150, then when I change the rate of something, how am I affecting the other medications? Again, these are things that a new grad may not think of. And that's what we need to really work together to make sure that we're delivering the right medication to our patients. So I'll turn it over to Scott for the start of this one.
Okay, so areas of opportunity for innovation really is a multidisciplinary team. Provider, nursing, and a pharmacist and IMT and thinking of order sets and making things in the EMR is absolutely a must, and it's demonstrated every day. Provider is, responsible for getting that desired medication for that desired indication. Nurse for administering, and if it's going to be peripheral or central, and pharmacists on dispensing consideration, stability, osmolarity, compatibility, and again, all that wrapped up in that collaboration is key. And that was demonstrated at our institution with our heparin order set. We have had heparin order set for a long time, and our EMR had developed a native heparin infusion protocol, and that the collaboration with nursing was key, and we still actually see it today. We are making headway on what we had built prior. We released the native EMR heparin infusion protocol, and it wasn't until nurses were able to use it and see it and changes and modify it. We went from a heparin protocol where a provider would order a high dose or low dose, no bolus, and the nurse then would have to do the order and put in the high dose, the low dose, no bolus, and order the bolus and the rate. Afterwards, in that collaboration and utilizing the new EMR function, now the provider puts it in, the provider orders the bolus and actually orders the initial rate, and then the nurse takes it from there and depending on the labs, does the titration and changes it. And up to date now, taking and building on that, we have seen where we can even become better with that. There's screens that may be a little too busy, or labs that are there that may not be recent, and we need the more recent labs. So again, working with nursing to get that to be the best product as possible, and not have the order set as be a system issue for the nurse, and set the nurse up for the most success.
And then a couple of other examples, just very quickly. I'm sure many places have put sepsis antibiotics in the automated dispensing cabinet. We really saw a drastic reduction in time from order to administration. I'm the sepsis coordinator for my facility. I monitor that. Our time from order to antibiotic has been drastically reduced. We're in the 25 to 27 minute range, and that's an average over a month's time. So again, that's a huge improvement. Medication titration orders, again, many places are working on this. We actually, as a very large system, we have a national policy, titration orders that have range orders. We worked actually with Robert Campbell, who is the Senior Director of Standards Interpretation at the Joint Commission, to make sure that what we're doing as a very large system is accurate. And he said, range orders are not taboo. Joint Commission never said, don't use range orders. Use them carefully, use them as intended, make sure that your staff understand how to do them. But this allows a critical care nurse to be able to titrate a medication within a range based on patient tolerance, use their critical thinking skills to really do a good job and not be tied to a single dose increment or time increment. So again, it's just an incredible opportunity for collaboration.
Okay, so your unit-based pharmacists and participation at codes, think ER pharmacists or code pharmacists. This has been integral working with nurses in this area. It's helped us optimize our crash carts. The pharmacist can be there and confirm dosing. They can prime the pump, grab the medication. We've had where the pharmacists going through the epinephrines or the D50s, and there's 6 of each in the crash cart trays, and the pharmacist can contact them inpatient pharmacy and have them tube more or obtain more drug. So that collaboration is integral in that code team, so much so that we've expanded in using that demonstration at our facility to have even more coverage, pushing towards that 24/7 infusion. And interest of time, we'll move to the next slide.
Yeah, and I'm very jealous because we don't have a pharmacist at our codes, and we would greatly love that.
Okay, barcode scan rates. Think with this, not only the regulatory, we want to get our BCMA, of course, we want that greater than 95%, but we obviously want that for the safety, that we have the right drug going to the right patient at the right time. And also with the barcoding and working with pharmacy, and it can be through, as is in our facility with our medication safety, that we have the drop downs when that doesn't work. Is it the fact that the barcode is damaged? Is it the fact that there's Medispan updates and that the new NDC that the manufacturer's putting out, it just needs to be updated? And that keeps that going so we can keep that 95% barcode rate and or higher for safety for our patients. Smart pump library guardrails. Again, you want that at 95%. The utilization, we want to use it 100%, but the goal is obviously keep it above 95%. And that can be for regulatory as well, but also for safety for the patient. And where that comes in is we can align our group with pharmacy and nursing work together for those guardrail, that library, aligned practice with the guardrails themselves, the upper and lower limits. And that way you keep down the alarms and that alarm fatigue to be alarming only when it was needed. Narcan administration, of course, we look at that and collaborate with nursing. That obviously in the ED, there's chances that we're going to be using that. That's from folks could be exposed from the outside, but internally. And you could even exclude, if you need to, the OR areas, but med-surg areas, ICUs, using that Narcan usage to say, how was our opioid stewardship? And did we have dose stacking and what have you? Next slide.
So we're going to talk a little bit about barriers and then get to our case studies. So again, the barriers are important. We work in silos. Pharmacy might be just a voice at the end of the phone, or they may be a very integral part of how I do practice as a nurse. Lack of resources, briefly on experience complexity gaps and conflicting sources of information. So I'm going to call Scott as a relatively new grad. It's been a while since I've been there, but I'm going to pretend to be a new grad, and I'm going to call Scott in pharmacy with a typical, maybe a distress call. Okay, so Scott, I'm Barb, and I'm working on the PCU unit. I got floated up here tonight, and I am really, I'm not sure what to do. I've got this patient, and I've got so many things to do for him, and I really don't even know what order to do it in. I'm supposed to give him vancomycin. I've got to give him a dose of IVIG, and I've got to give him a unit of blood tonight. He's got a little 22 in his thumb. He's got an IV in his antecubital space that's already painful to him and a little bit red. I don't even know which one to use. The doc wants me to do blood cultures. He's got this weird thing in his chest. They're calling it a Groshong. I've never even seen one or heard of it. He's getting TPN through that. I don't even know where to do the blood cultures. I don't know what drug to give first. I don't even know where to give them. The charge nurse is busy. I can't even get the time of day for many of these staff up here. Can you help me?
I certainly can. First of all, there's a lot there to unpack, and we're just going to take one thing at a time. We're going to apply whatever policies that we need for your area, med surg or ICU, and we're going to take it one step at a time. So if we need to give an antibiotic, first thing, if we need to give an antibiotic, we need to look what you have in your line. And remember, IVIG, that's a blood product. So remember that we can't use IVIG or any blood products. There's no co-administration with medication. So let's take and we're going to put in a hierarchy and what comes first and risk stratify that on down. So we'll give that antibiotic. We'll make sure that nothing else is running, and then we'll time that IVIG. And if we have to, we'll retime medications. And if we have to, on top of that, we'll get a hold of the provider just to make sure that we're not compromising care. So we will definitely get there, and we'll make sure that we'll look at trissels and make sure there's no incompatibility issues. And I'm probably going to need your help because some of that nomenclature I'm not familiar with. So you may have to explain some of that to me.
Yeah, so we talk on the left side that, we do speak different languages, and I talk to pharmacy all the time. They speak pharmacy, I speak nursing. So we do need an interpreter, and we need to ask for clarifications. Our pharmacy really wants us to understand morphine milligram equivalents more readily, and that is something that nursing doesn't. So the area under curve, all of those things, we need to get together and really explain better. And then, yeah, Scott, if you can touch on the competing priorities next, and then we'll get on.
Yes. So time administration, this is a thing that's seen in regulatory all the time, and for the preparation itself. If it's a sepsis patient versus following policy, there's time critical meds, administration versus dispensing. We need to administer that medication right away, but this becomes a patient-specific IV, and it needs that nursing and pharmacy collaboration to time that. And we see this all the time. We see this rather can be with chemo. You have to have a cutoff time for chemo to have it ordered by a certain time so we can safely prepare it. But what if this is an acute? This is an AML, and we need to get that preparation made, and we need to get it up there as soon as possible. So we've got to collaborate back and forth to make sure that we get that patient the therapy that they needed versus the time constraints. Was the medication sent? Yes, it was. Explain the opportunities that, hey, did this patient get transferred from the ED per chance, or was this patient on a different unit? And whether pharmacy or nursing looks at that prior unit, but we see that this was already dispensed. We will certainly get that medication to you again if we have to, but it may be faster to go to that other unit and see if that's there. And again, rescheduling of these medications around blood products, and or doing where pharmacy will do a time change and make sure that this patient still gets their medication and communicate with a nurse, and so we can get all the therapy that they need.
And this one is
okay.
yours.
Yep. So lack of resources. Quick, all we wanted to relay on this one is, what do you do if you don't have that 24/7 coverage, which Barb had mentioned about potentially a code pharmacist or an ER pharmacist. And even in our facility, we're pushing towards that 24/7, but we're not completely there on 7 days a week. So working with pharmacy and that nursing, do they have, what's your primary drug reference, Lexicon, Micromedics, whatever, but do they know how to use it? Can they demonstrate that they know how to use it? Do they know that, like for Lexi drugs, for example, that there's trissels embedded in it? And if it is, that they know how to go to trissels and interpret those compatibilities. Have a strategy for a premix. The items that are premixed from the manufacturer, of course, pharmacy is always encouraged with ISMP, but even regulatory, always get those things that are premixed as a hierarchy. It doesn't have to be unilateral that way, but you always want, if a manufacturer has a premix out there, you want to give that a higher priority of purchasing. If not, if pharmacy makes it that there's a quantity that's needed in an area, in an ER, in an OR, in an ICU, that if it's either not commercially available or we're not buying it, that we have a minimum par quantity for those times that the pharmacy is not 24/7, that it's in the Pyxis, and that it has dating that makes sense, that it's not 24 hours unless you have to, that you can give it 3 days a week, and whatever's good for that area or that purpose. A well-vetted USB 797 and 800 risk assessment. This is going to be paramount. Are these medications a hazardous drug and nursing can't compound it and it's still in the Pyxis, which we'll get to later, that this is a holdover from a risk assessment? And if so, can we have it in a final product that nursing can administer and even have the tubing primed or availability in a final form? And then again, IV push versus intermittent infusion versus PO if the gut works. Knowing those strategies for those areas when pharmacy is not available, that if we don't have a medication that pharmacy would do patient specific as a piggyback, can we push that in these off times? Next slide.
So just to let you know very quickly that we have a significant experience complexity gap within nursing, and I've got it defined at the top of the slide. I gave you a good illustration of a new grad that was put in a situation that they really didn't have the knowledge to critically think through, and they didn't have the resources around them because of the ratios and the busyness of the floor. So the experience complexity gap is a net decrease in the expertise across the nursing workforce, simultaneously with increasing complexity in patient care. And I have to let pharmacy know that this is truly happening. We lost many seasoned nurses before COVID, during COVID. We have marvelous new young people coming into the profession, but they are not getting the replications and the application of critical thinking that tends to create task-oriented thinking. What we need to do is help them to create critical thinking development, but that takes repetition and application. So again, that scenario that we gave you, Scott coming alongside to say, okay, let's unpack this, let's slow down a little bit, let's really think this through. That's what has to happen. Typically, though, nursing just can blindly follow orders and not necessarily critically think through an issue. So again, we have a significant area where we have to come alongside and create tools for these new grads.
Yeah, and Barb, if you agree here, we got a few minutes. Maybe we can move forward. We can grab these other slides and get that information through our case studies.
Yeah. Yeah. The competing resources are important. We need to make sure that, say, when he says trissels, that the provider maybe that are important. And I just want to call out one thing down at the bottom, the use of the midline catheter. I'll cover that a little bit more in the next session. But there is significant conversation in this space that the midline catheter can be used very similar to a PICC line, and it really can't. It's for peripherally compatible medications, not for continuous vesicant infusions. And we have some really good resources coming out very soon to really help that. So we'll get into our case studies because we know we're into the Q&A time. There's so much information we can include here. We're going to include just a couple of things. I have a very fast case study, the drug diversion one, of a young nurse that noticed that a very seasoned nurse came out of rooms that she wasn't assigned to, and that seemed strange. And so he actually did some investigation, got pharmacy involved, and actually found that this nurse was diverting fentanyl out of bags or narcotics out of bags and replacing it with saline. So pharmacy got involved. They took down all of the narcotic infusions going on, and that day replaced them with new tubing and bags, and found out that indeed she had been diluting the medication here. So again, a new nurse using great thinking raised the alarm on this. They were able to hopefully get this nurse help, but definitely they were able to give safe patient care. So yeah, I'll let you choose maybe, Scott, since we're kind of at the end of time.
Yeah, do we want to get right into the QA?
We do have a couple of things you can read through on hazardous medications and great opportunities there. And we actually have, again, hopefully you've seen the opportunity for crucial collaboration between these two. You can take screenshots. I'll hover here. There are marvelous resources made available here. When you type in those, they are public domain. So again, if you take a screenshot of that, you can get those. And yes, Jackie, if we wanted to go to Q&A, we might be able to squeeze in a question or two.
Sure, Barb. I know that we're at time here, but we do have a couple of questions in the queue. The first one I think probably is for you, Scott. The 2020 NIOSH appears to still be listed as a draft, and it says that it does not represent and should not be construed to represent any agency determination or policy. So are you still relying on the 2016 NIOSH guidelines?
That is a fabulous question, and we can actually on the second one, but I will address it here. So you are obligated to look at the 2020. It is a draft, and we looked at the 2016 is the last one that's official. Then there was a 2018, and then now there's a 2020 draft. Still waiting on that to be officially ratified. So what we're doing is looking at that 2020 draft, using that as a jumping off point, making sure that anything that is finalized in 2016 that is not changed in 2020, that we keep 2016 as is. If it's changed in 2020, then we assess whether we're going to accept or not, which actually is what USP says, and wait until officially that's been ratified, especially when it's either table 1 or table 2. If this is a table 2 and it's a reproductive risk, and is that a good study? So unfortunately, not a great answer, but you got to build on 2016. If nothing's changed in 2020, then you can leave that as is. If it is, you have to assess for yourself until it's officially been approved or ratified.
Okay, thank you, Scott. If anyone has any additional questions, I have placed my email address in the chat for you to email the questions to me, and I will forward them to Barb and Scott to respond to before our next webinar. Thank you, Barb and Scott, for such a very informative presentation and so many examples of how pharmacists and nurses can collaborate. Also in the chat is a link to the survey. Please take some time to complete that so that we will have some ideas for future webinars. Also, we hope you can join us for part 2 of this webinar series, which will be Wednesday, December 18th at 12 noon Eastern. And I also mentioned in the chat that a recording of this webinar will be posted on our educational website, News to Infuse, in the near future, and a link to that is included in the chat. Thanks again, and this concludes today's webinar.
Thank you, Jackie.
Thank you.
You're welcome. Take care.